you can follow UCAS strictly for all, except those where UCAS breakpoints are not there. You can use the CLSA. But if you do half CLSA, half UCAS, then it will become a problem, because the QC recommendations, the methodology wise, there are a lot of differences between CLSA and UCAS. Okay, there are some zone diameters which are sensitive by CLSI. If you apply UCAS breakpoint, they become resistant. So it is quite tricky. I mean, your entire antibiogram will change if you have a mixed policy. Better to follow CLSA policy because the majority of Indian hospitals are following. So better to adhere to CLSA policy. So this is all about M100 and M45 what we have discussed. Now we will move on to and also M02 we have discussed about QC and basics of DST. So three important CLSA documents we have finished, and again a yet important CLSA document is M39. The M39 is for antibiogram, and antibiogram is a very important area because this is what is important for the clinicians to choose the empirical antibiotic. So I will be briefing a 5 minute introductory session, then Pallab sir will be going to speak about the overview of antibiogram, following which we will have other important sessions of antibiogram. Okay, so this is a case scenario of, for example, you can see that in this case scenario, sorry, in this case scenario, you can see that 25-year-old male, medical oncology ICU on central line. He has developed a fever and chill, and on central line also you have erythema and swelling. A temperature is raised. The clinicians are suspecting a provisional diagnosis of CRBSI, and the blood cultures are sent. What they have to do, they will, which antibiotic to start. The clinicians are confused which antibiotics to start, because most of the clinicians, they say that the ICU is like a battlefield of Mahabharata. This particular slide I have taken from my dear friend Dr. Sumit. So I acknowledge him for this slide. So the ICU environment is like Draupadi Bastaran environment, where you can see that the patient may mimic Draupadi, whereas Dushashan is going to be the infection, and the relatives, threat, litigations, all are looking at you, asking that which antibiotic you are giving, and these are the residents of the ICU. These are the clinical residents of ICU. They are quite confused. Some of them are telling that it is a case of CRBSI, so staph aureus is the most common cause. Let us start cloxacillin. Some of them are telling that no, vancomycin is important, because my consultant has told to start vancomycin. So the residents are actually confused. They are clueless to start which antibiotic. And you remember law, MCI, and more so everybody is looking at you. And nowadays even the patient relatives who are looking at you, they also can google it, and they will find out that why you have not started antibiotic yet, why you have started vancomycin, why you not started cloxacillin. Many times relatives also put pressure to start antibiotic. But my dear friend, what Lord Krishna says is, he comes to the battlefield like a savior, and he saves the residents, and he advises the resident that please do not go for the mind line. Mind line are the people who are surrounding you and they are influencing you. So do not go for mind line. Follow the guideline, follow the guideline, and the guideline says that you have to go for evidence-based empirical therapy, and how and which evidence will decide empirical therapy to use. This is the hospital antibiogram, which is going to decide what antibiotic to be used. The hospital antibiogram, if it is available, if the clinical microbiology team will provide the hospital antibiogram to the clinicians, then you can see that in this case, for example, the Staphylococcus aureus sensitivity to oxacillin is 62%. So MRSA rate in this case is 38%. So accordingly, you can decide that the MRSA rate is high, so I can go for vancomycin. If the MRSA rate is low, then you could have gone for cloxacillin. So this is called as evidence-based empirical therapy or antibiogram-based empirical therapy. So these are the various sessions. These are the various chapters of CLSI M39. So this is the fourth edition of CLSI M39. It is an old edition which is available now. The next edition is coming up. The fifth edition will come in 2 to 3 months later. Right now, we have received a draft document of fifth edition, a draft document of fifth edition, which the CLSI has not circulated for sale. It is only circulated for making the comments. It is a proposed draft, and for this document also, I would like to acknowledge Dr. Sumit Rai. He is a reviewer from India for this M39 document to review and to pass comments. So with his help, I have got this document, and this particular session we are going to discuss on detail about this draft document, and these are the various chapters which are there in this draft document. So first we will have the overview session by Pallab sir, and following which we will have the various other type of antibiogram. The basic antibiogram is called as routine antibiogram. This session I will be taking after Pallab sir's session. After that, the other type of antibiogram, enhanced antibiogram, Dr. Dipasri will take, and then the other type of antibiogram, Dr. Ketan will take. Okay, so then again the use of antibiogram, again this is what I am going to take little later. So sir will give a overview. You will have a very good bird's eye view of antibiogram in the first session. Then you will have a detail of the discussion subsequently. I request Pallab sir, uh, Pallab sir, uh,
Yeah, thank you.
audible sir.
Yeah, am I audible?
Yes sir, yes sir, you are
Oh,
audible.
let me share my screen. Right. So is my screen visible?
Yes sir.
Yes, sir.
Okay. Thank you very much, and good morning, everybody. I'm very happy that Dr. Apurva has kept a detailed session on antibiogram this time. And just like yesterday's presentation, I'll again give you a very short overview, bird's eye view. And after that, most of the things will be threadbare, discussed in far more details in the subsequent presentations. And thanks, Dr. Apurva, for sharing the draft, recent draft with me. But naturally, I didn't get enough time to go through it. So my presentation is based on the 2014 edition. Uh, I think if there has been any changes in subsequent sessions, you can take them up. So uh, let me start with the very first thing. Why do we need an antibiogram? We need an antibiogram because it helps the clinician select empirical antibiotic therapy. It also helps an epidemiologist to track trends in antimicrobial resistance over time locally, and for surveillance for emergence of drug resistance bugs. So it actually supports multiple things. Firstly, it supports clinical decision making for the clinician, local antibiotic protocol revisions, formulary decisions, infection control interventions, and antimicrobial resistance containment strategies. Well, it's also an essential function of the clinically microbiology lab and the clinical microbiologist to prepare their own antibiogram and help the clinician, epidemiologist, and surveillance and infection control people. Now, the main problem with cumulative antibiograms is that unless we know the details about how to prepare, what are the dynamics, and how to interpret them, there is poor comparability of antimicrobial susceptibility statistics between the institutions, particularly because there are non-uniform inclusion criteria. For example, I give you an example of coagulase negative staphylococci from blood or from pus. There are institutes where they discard, or rather they do not give any value, they don't report any of the coagulase negative staphylococci from pus or from blood. There are situations where they report all of them. There are situations where they have their own criteria when to report, when not to report. Or report means when to consider them as significant and when not to consider them significant. Then second point is that many people use very simplistic calculation approach, and there is a lot of diversity of calculation methods by the labs which make them non-comparable. There is a strong tendency to overestimate drug resistance rates. You will see that most of the papers that come to many of us for reviewing, you will see they will always talk about resistance. They do not talk about susceptibility, whereas the dictum by most of the agencies, international recommendations is that talk about susceptibility, do not talk about resistance. Do not glamorize resistance, rather glamorize the susceptibility. So what is by definition a cumulative antibiogram? So it's a susceptibility test data summary. So it's a very complex, you will see that there are lots of components in the definition, all of which probably requires discussion. So it's a report generated by analysis of results on isolates from a particular institution in a defined period that reflects percentage of first isolates per patient of a given species susceptible to each antimicrobial agent routinely tested. Look at how many explainable components it has. So it is from a particular institution first. Second, it must be in a defined period. We'll come to that. What is a defined period? So it should be presented in percentages, and percentages of first isolates per patient in that defined period. And it should be by given species. You cannot have antibiogram of Klebsiella species or Enterobacter species. You have to base it on the species identification, which is considered to be the basic point of reference for clinical bacteriology. Then the point is it should show susceptible data rather and not the resistance data to each antimicrobial agent, not every antimicrobial agent, each antimicrobial agent routinely tested. Well, now it's essential to have uniform policies, rules for data collection, data compilation, data presentation, and data analysis, because in that way it ensures comparability, it ensures reproducibility, and it allows merging of data between and with other institutes at regional levels, country level, and global level. Nowadays, we have the WHO GLASS platform, which actually wants to compile the data from different countries. And therefore, unless all the data they have common denominators in terms of creation, compilation, presentation, and analysis, it cannot be merged into one. So if you have, this is just a couple of examples of how to have uniform policies. Say, for example, if you have more than one isolates from the same specimen, it should be unambiguously reflected. Two isolates from blood culture from the same blood culture specimen, say one is Staphylococcus aureus, one is Staphylococcus epidermidis, then both of them against the same specimen number, against two isolate numbers, have the details available. There are situations where we put up multiple test panels. Maybe we put up the first test panel on day one and second test panel. So the second test panel results should not go onto a separate entry. It should come to the same isolate on the date of collection of that specimen. Here, I must say another very important thing, that sometimes, that we all recommend cascade reporting. That means we withdraw reporting certain antibiotics, but we do keep the data with us. If required, we release the data with them. But cascade testing has got a problem, because the organisms which are tested on the subsequent day, they are actually a highly resistant subset of the whole number of organisms that we actually test. And therefore, they will always show higher resistance. So they actually do not reflect the behavior of the antibiotic for that organism from the whole lot of organisms. They only show the results of a subset which have been resistant to the first or second group of antibiotics. Then only they have been tested. So sometimes there is over representation of resistance. We can discuss it more later on. So when we analyze the data for a defined period, the basis of it is the line listings, and then we create what is known as a cumulative statistics. Before producing the cumulative statistics, we must remove or edit the incorrect data. So I show you just a representation of the line listing. So this is the basis for cumulative antibiogram. And then we have the analyzed results. So for example, results of susceptibility of Enterobacteriaceae to various antibiotics tested. Results should always be given in a tabulated form where actual numbers are there. And also, in addition, you can give in graphical form, which are easy to interpret rapidly, but doesn't actually provide you all the detailed data in the antibiogram. So this is the way analyzed. Now, what are the essential information that should be there in the
The
line list?
screen is not visible.
Uh, isn't my screen visible?
Screen is visible, sir.
No, sir.
So there must be some bandwidth problem
Sir,
with specific
you just you
recipients.
may have internet problem, I think.
Huh.
For us, it is visible, sir.
Okay, I'll continue. So there are certain information which are definitely required and certain information which are desirable. For example, unique ID SEER number, and which facility is it if a lab is serving multiple facilities. It's desirable to have the age of the patient for subsequent analysis beyond simple susceptibility, and then sex of the patient, location when sampled, because the same patient sample can come first from an ordinary ward, then from the ICU. The clinical service, which medicine, surgical, gynecological, admission date. If we have admission date, then it always helps us to decide whether it's a hospital acquired or a community acquired infection. Then the specimen information. It's required to have a specimen number, the specimen type, and the date and time of sampling. It's desirable to have a body site because that always helps us in reporting. For example, you get a pus sample from an ulcer and nothing else is written. If the ulcer is from scalp, the normal flora expected on scalp is different. If it is from the upper half of the thigh, the normal flora expected from the upper part of the thigh will be different. So when you have a mixed flora, you cannot decide which one to report, which one not to report, unless you actually know which is the body site. So it's always desirable to have it. Then organism information. Required is identification to species level. Desirable isolate number if multiple isolates. Mechanism to keep taxonomic continuity. That means certain organisms have changed their names at various periods. For example, Pseudomonas maltophilia becomes Xanthomonas maltophilia, becomes Stenotrophomonas maltophilia. So there should be a mechanism to identify and merge them later on for analysis over a period. Whether it's colonization or infection, one should actually include only those which we are confident that it has contributed to the infection. And I have already mentioned about community or hospital acquired. Susceptibility information that I won't go into details because that has been already discussed in detail and will be discussed. So you should have quantitative measurements like MIC or zone diameters and categorical interpretations both. And if expert rules are there, particularly in automated systems, they should also be mentioned. Okay, data analysis. What should be the frequency of making a cumulative antibiogram? It should be at least yearly. It can be more frequent if large number of isolates are there, if new antimicrobials are introduced and we rapidly want to disseminate the results of this new antimicrobial to help our clinicians. If clinically important changes have been perceived, suddenly we have seen a very high resistance in one species to colistin, so then it should be communicated. The problems of high frequency antibiogram is that there may be seasonal variations, and therefore those seasonal variations can become a problem. Sometimes the numbers are too small and therefore it gives wider confidence interval. Now, in the next two slides, I'll just deal with a very important concept of confidence interval. You know that CLSI always says that you must calculate the percentage susceptible only when the number tested is 30 or more. Now the question is where from this 30 number has come. So I will give you an explanation of that 30 number. You know that whenever we statistically arrive at a number, so don't be distracted by the complicacy of this particular table. I'll explain you. So for example, if I say that a particular organism has shown overall 50% susceptibility. Now, this is a statistical derivation from multiple organisms. Now, this 50% has got actually data on either side of 50, which has been ultimately the mean has been taken to 50%. Now, how much it actually deviates on either side of the 50%, it depends on what is the sample size. And that actually shows us the confidence interval. So if you look at the 50% an organism showing 50% susceptibility, if the sample size is 10, then the values can be anywhere between 19 to 81. If it is 100, the value can be anywhere between 40 to 60. If it is 1000, the values can be anywhere between 47 to 53. So what I want to actually show is that as the sample size keeps on increasing, you will see that the confidence interval keeps on decreasing. Here the interval is nearly 81 minus 19, that means 62, 31 on either side of 50. And here you can see that it's only 3 on either side of 50. So that means with increasing sample size, confidence interval narrows down, therefore reliability of the data increases. I will just take this part of this table in the, and another thing is that even the confidence interval is dependent on what is the susceptibility percentage. If you see that near 50%, the confidence interval is highest for the same sample size. As we go to the extremes, the confidence interval gradually reduces. Here it is 45. In 20% it's 53, in 30% it's 58, 40% and 50% it's 62. So I will take this part and show you graphically. So if the sample size increases from 10 to say 1000, in an organism which has 50% susceptibility, the confidence interval gradually reduces from 31 on either side to 3 on either side. Here I have shown the confidence interval in lines. Now, if look at the behavior of these lines, from 10, as we go to 20, there is a substantial reduction in confidence interval. When we go to 30, again, there is a substantial reduction. And after that as we increase the sample size from 30 onwards, the gain in reliability becomes more and more modest. And that is the reason why the CLSA has taken 30 as the minimum number for percentage calculation. Okay. Isolates only first isolate of a species per patient per analysis period, irrespective of body site, susceptibility profile, phenotypic characters, events. The database to store all isolates, the database should store all the isolates tested, but you should have an analytic software which should select only the first isolate per patient per calendar year for cumulative antibiogram if you are doing it yearly. Only isolates more than equal to 30 should be included for percentage calculation. If the number is 30, what to do will come later. Only clinically significant isolates to be taken up. Antimicrobial agents, only those routinely tested and appropriate for the species and for the disease syndrome should be reported. For surrogate testing, for example, cefoxitin for oxacillin, report the agent that is represented, not the agent that is tested as a surrogate marker. Similarly, oxacillin for penicillin in Streptococcus pneumonia, we shouldn't report it as oxacillin, then the clinician will get confused. Shall we treat the patient with oxacillin? Selective reporting, as I have already said, that cascade reporting is the rule, but cascade testing introduces bias, therefore not to be included. Supplemental drug testing not to be included. Calculations, report percentage sensitive only, do not report percent resistant. And already we have discussed, do not include earlier, that do not include percent intermediate. For use the current breakpoints, sometimes the breakpoints are revised. For example, I have got data which includes fluoroquinolone breakpoints which have been subsequently changed about a couple of years back. So when I have to compare the data, old data with the new data, be careful about the comparison unless you have updated the old data with the new breakpoint guidelines. So you have to update it using using the newer guidelines. MIC to be recorded to 2 decimals only. Dilutions are 2 decimals only, and dilutions other than twofold dilutions to be raised to a higher CLSI twofold equivalent. I'll give you an example. You will see that in the e-test strip, there are values in between two-dimensional steps, twofold steps. For example, 1 and then 2, then 4, but in between we have 1.5 and 3. So when we are actually reporting it, we should not report the in-between values. We should report only if it is between 1 and 1.5, we should raise it to the next value to 2 and not 1.5. Off-scale MIC values as uninterpretable if breakpoints are revised, because you will see that we always say that most of the automated systems, they are MIC based. Okay. But ultimately, you actually get the MIC in less than 30% of the isolates, of the antibiotics, because in majority of them, you get a result which is more than X microgram per ml or less than Y microgram per ml. So actually, you have not got the result in it. So these are called off-scale MIC values. They are actually uninterpretable. The calculations we have already said. Okay. Next is validation. If less than 30 isolates of a species are there, think, is it essential to include the species? If included, either give the absolute number without a percentage or put a note that less statistical validity. Sensitive in vitro but clinically inappropriate should not be included. For example, Salmonella typhi aminoglycosides, they have no clinical role. Even if we have wrongly tested a Salmonella typhi without knowing its identity on the first day, this report, after we have known that this is Salmonella typhi, should not be included in the final report as well as the cumulative antibiogram. In those situations where only sensitive category is described, percent sensitive should be 100%. Else, one should investigate the non-susceptible ones. Okay, we always try to give the percent susceptible to single antibiotics. It's sometimes useful to examine the percent sensitive of isolates sensitive to one or both the drugs in combinations. This will assist in empirical combination therapeutic recommendations. For example, I give you an example here. Pseudomonas aeruginosa, somebody has tasted 814 strains of Pseudomonas aeruginosa, 69% susceptible to ciprofloxacin, 80% ceftazidime, 79% imipenem, 86% tobramycin. Now, truly speaking, individually cipro and ceftazidime is 69 and 80, but 86% of the isolates are susceptible to either ceftazidime or ciprofloxacin and or. Similarly, imipenem and ciprofloxacin 84, ceftazidime and tobramycin is 91, say imipenem and or tobramycin is 91. So this type of combinations can be arrived at if you have the line listings. Clinicians, they usually do not have the access to the line listings there, but they need this particular data very importantly, and therefore sometimes they will come down and calculate these things to have their empiric therapy guidelines. So if we can give such type of information, this becomes more valuable for the clinicians. Okay, one should give table and graph with data accumulated over several years. Staph aureus percentage sensitive for oxacillin, OPD, IPD, if possible, the breakdown for even the ICUs. So similarly, the other breakups for say MRSA susceptibility, MSSA susceptibility, if we can carry out, that will also give very important information to the clinician. If you can show the trends over the last few years, the way CDDUP usually gives, nowadays ICMR in their annual report has also started giving the trends, because I edit a part of that. So that also becomes valuable to the clinicians and epidemiologists to monitor the trends of drug susceptibility. I will give lastly, I'll give you one particular thing, again, a complex table, but we are not going to use the whole table. Now, see, for example, suddenly I see that one organism, I have a sample size of 100, and one organism which last year showed susceptibility of 80%. Now this year, the susceptibility has gone down. Now, how much the susceptibility should go down to say that this has gone down significantly? There are tables available which, on the basis of your sample size and previous year's susceptibility, it shows how much should it go down to make it significant. For example, with a sample size of 100, its initial susceptibility of 80%, it should go below 66% to become significant. Otherwise, this may be because of chance happening. Similarly, how much it should be raised is shown in the next table. Say 100 sample size and initial 80%. It should go beyond 91% to say that it has gone up significantly to mention it. So the last slide, there are limitations of antibiograms. First of all, they do not consider patient factors. like past history of infection, antimicrobial use, therefore not useful for guiding treatment in recurrent or relapsing forms of infections, not generalizable to all patient populations, locations within the facility. For example, immunocompromised patients, HIV positive patients, they may require separate compilations, not generalizable to different facilities like community or others, not useful for monitoring the emergence of antibiotic resistance during treatment because we are taking only the first isolate and not the subsequent isolate, not useful for identifying trends of cross-resistance to other drugs. So that means if one organism is resistant to one particular drug, what is the probability it will be resistant to another particular drug? Why? So that also is not available. So lastly, antibiograms, they help antimicrobial AMSP, antimicrobial stewardship program, by helping in antibiotic selection, guideline development, identify the resistance strains, and the line listing can give us guidance about phenotypes, may point to genotypic mechanism of resistance. You may be aware about the Livermore's article in early this century, which shows how you can predict the genetic mechanisms by looking at the phenotypic resistance to different drugs, and it may be extrapolated to other drugs. Multiple drug determinants, of course, blur the predictability. So with that, I'll end my overview, and thank you very much for your kind attention.